So what I want to go over right now is an outline how you make a very quick diagnosis of wide complex tachycardia. The mechanism and pathophysiology we go over very, very quickly. So you need to recognize wide complex tachycardia. We go very briefly over treatment, and then, but the most part I really want to spend on making the diagnosis with you practicing what you just learned during this lecture, okay? So, if you have a wide complex tachycardia, there are only 3 differential diagnoses. It could be SVT with pre-existing or functional bundle branch block. And if it's a bundle branch block, it should look like a typical right or a typical left bundle branch block, okay? You could have antitromic circus movement tachycardia over an accessory pathway. This is very difficult to make the diagnosis and differentiate this from ventricular tachycardia because it can look exactly the same as the basal origin of a ventricular tachycardia. So these are the 3 differentials you have: VT, SVT with pre-existing or functional bundle branch block, or antitromic circus movement tachycardia. So atrial flutter, as you know, is a circuit that goes around in the right atrium. However, you can have something like this. That's how atrial flutter looks like, right? It's fairly slow atrial flutter, negative P wave 2-3 AVF. However, if you have bundle branch block, it might look like this. Okay, there's a P wave. This is atypical atrial flutter with a wide QRS complex. This might be someone who is on flecainide and has a very wide QRS complex. Okay. Atrial fibrillation, as you know, typically is irregular, but if you have a bundle branch block on the right side, you can have this EKG, and we just went over this because this is a functional right bundle branch block, right? So if this were more regular, you think, could this be VT? In this case, it's very clear that this is atrial fibrillation with a functional bundle branch block. Now, this is how VT looks like, and you can explain a lot of phenomena you see in the ECG by remembering this picture. So typically what ventricular tachycardia is a reentrant circuit that is located, for the vast majority of the cases, within the left ventricle. And depending where the circus movement sits, you can explain how the tachycardia should look like. So what happens to ventricular tachycardia very frequently, you can have a reentrant circuit here that conducts retrogradely via the AV node to the atria, but at the same time, you have your sinus node that may fire at a regular basis. So you may have a sinus rhythm at 80 beats per minute, but you have ventricular tachycardia at 180 beats per minute. So if this ventricular tachycardia is slow enough, every once in a while, the sinus beat that originates in the sinus node can conduct to the ventricle and can capture the ventricle instead of your reentrant circuit here, and then you have what's called capture beats. But more frequently, if the sinus node that fires at 80 beats per minute conducts partially down your ventricle while the ventricle gets activated by your reentrant circuit, in this case you have a fusion beat. So you have basically a surface EKG that is generated partly by your reentrant circuit in the left ventricle and partly by the sinus node excitation that conducts down your normal conduction system. So this is called a fusion beat. So these are typical phenomena that you might see during ventricular tachycardia. Now, depending where this reentrant circuit sits, if it sits very laterally, very far away from your conduction system, you typically have a very wide QRS complex. However, if this reentrant circuit sits very close to the septum and to your conduction system, or even uses part of your conduction system, typically you have a more narrow QRS complex. So remember this, what you see in the surface ECG can be explained where your reentrant circuit sits during ventricular tachycardia. Okay. Often these reentrant circuits originate in scar tissue. If you have idiopathic ventricular tachycardia, it might be different, but for the vast majority of the cases, you have scar-mediated ventricular tachycardia, and this explains sometimes also the ECG that you see in the surface. Okay, so this is a pretty ugly tachycardia. What do you think what it is?
VT.
Who said that?
John.
John, okay, John. So John made the diagnosis in, how long did it take you, John? 5 seconds?
Yes.
Okay, good. So John heard this lecture before, so he made the diagnosis in 5 seconds. So everybody needs, after the lecture, needs to be able to make this diagnosis in, I give you 15 seconds. Okay, so this is VT, and why this is VT, we go over in a second. Simple approach for you guys to make the diagnosis in 15 seconds when you call to the emergency department, okay? Good. So what you need to know is the diagnosis can be made if you have a 12-bit ECG in greater than 90% of the cases. There are some cases where you have still doubts, and the rule is if you have doubts, treat it as if it is VT. Nobody will blame you for this. But in 90%, you can be fairly sure what it is. If a patient is stable with the right complex tachycardia, please get the ECG. Don't let the emergency department physician shock those patients out if they are stable, because we need to have this ECG if you want to ablate this tachycardia later on. If you doubt, always treat it as VT. Do not use these criteria for making the diagnosis. Age of the patient, hemodynamics, regular or irregular. In general, tachycardias will get regular over time, but at the beginning and at the end, they might be a little bit irregular. Okay, so let's go over some criteria how you make the diagnosis. So if your QRS width in a right bundle morphology right complex tachycardia is greater than 140 milliseconds, or in a left bundle branch morphology greater than 160 milliseconds, it's more likely ventricular tachycardia. And the reason is typically a right bundle, if I cut your right bundle, the QRS complex is around 140. If I cut your left bundle, is not, in general, not greater than 160 milliseconds. Okay, and that is unless you have antiarrhythmics on board. This is the rule of thumb. Okay, 140, 160 milliseconds. So this is a typical left bundle, right? You have no R wave, V1, V2, V3, tiny R wave in V4, transition abruptly from all S wave to all R wave from V4 to V5, and very wide QRS complex. So this is a typical left bundle, okay? If you have a typical left bundle, it's less likely to be ventricular tachycardia. So this is obviously sinus rhythm, but just remember, this is a typical left bundle, okay? This is a typical, fairly typical right bundle. It's not 100% typical because you see RS, R prime until V4, which is a little atypical. But typically you have a small R wave, big S wave, and then tall R wave, R prime. That's a typical right bundle, okay? So QRS axis. So if you have a right bundle branch morphology tachycardia and you have a left axis deviation, right bundle typically does not go together with left axis deviation. You can make the diagnosis of ventricular tachycardia. If you have a left bundle branch morphology and a right axis, it is VT. So remember, typical right bundle does not go with left axis deviation. Typical left bundle does not go with right axis deviation. Okay? And because of that, it's more likely VT. If you have right bundle and left axis deviation, this is 100% VT. If you have left bundle branch and right axis, more likely VT is not 100%. Okay, so remember, take home message, if you learn one thing, if you have an atypical left bundle, atypical right bundle, it's more likely ventricular tachycardia. Okay, that you all know. The concordance criteria. If you have negative concordance, so everything is negative, it's VT. If everything is positive, like in the VT that you saw at the beginning, it's VT, but it could be antitromic AVRT. Okay. So these are the criteria that the Brugada published in their papers. My boss always got very upset because he came up with criteria way earlier. This was Mark Josephson. So if you have an RS wave in the precordial leads, measure from the beginning of the QRS complex to the nadir of the S wave. And if this is greater than 70 milliseconds, and more specific, greater than 100 milliseconds, this is ventricular tachycardia. Okay? Beginning of the QRS complex to the nadir of the S wave. More than 70 milliseconds, better more than 100 milliseconds, you can make the diagnosis of ventricular tachycardia. So we have capture beat, I explained this before, or if you have fusion beats, this is very, very likely ventricular tachycardia. So there was a sign, it's called the Josephson sign. If you have a left bundle branch block morphology tachycardia and you have a notch in your QRS complex, this is more likely ventricular tachycardia in V1, V2. Okay, so I want to spend a little bit of time on these morphology criteria. And the morphology criteria are very, very valuable for you because if you have those, you can make the diagnosis very, very, very quickly. So if you have a left bundle branch block, look in V1 and look in V6. If the R wave in V1 or V2 is greater than 30 milliseconds, so roughly one tiny box, you make the diagnosis of ventricular tachycardia. Because a typical left bundle does not have that. You have no R wave. And if you have an R wave, it's tiny. But if the width is greater than 30 milliseconds, roughly one small box, you have the diagnosis of VT. And you're done, okay? If you have the notching of the down slope, so basically it goes down, little notch, goes down further, this is VT. Look in V6. If you have a QR in V6, you have the diagnosis of VT. In a typical left bundle, you do not have a Q wave in V6. So this applies for left bundle branch block morphology. If you have a right bundle, again, look V1 and V6. If in V1 you have a tall R wave, monomorphic R wave, if you have a QR, a big Q and a big R, or a small Q and a big R, or you have an RS complex, this is VT. Typically a right bundle, they don't look like this. Again, look in V6, if you have a deep S wave, or you have an RS ratio greater than 1, so RS ratio greater than 1, it is more likely ventricular tachycardia. Okay, so remember these criteria, and we practice them in a little bit in some of the tracing. You make the diagnosis very, very quickly.
Dr. Schmitt,
yeah?
A quick question about the criteria of the RS ratio and the right bundle. One of the AP attendings told me it's not reliable, it's only reliable in superior access. What's your take on that? Yeah,
so it's less reliable than the criteria in V1, no doubt about it. No doubt about it. But the access I would not put into consideration. But it's true, this criteria in V6 is less reliable than the criteria in V1 for right bundle branch block morphology. Okay?
Thank you.
Let me see quickly. So remember these criteria. Okay, so that is how you make the diagnosis. So the problem often is how to interpret telemetries. So as fellows, you often get called for consults, and you see they saw a wide complex tachycardia on telemetry, and you have to make the diagnosis. And this is much more difficult. But you get some hints what the etiology is. And this is Mansoor sent me this, and I want you to take a look at it and tell me what you think what this might be. So what I don't want you to do is, if you get a 12 EKGs with a wide complex rhythm, don't look for AV dissociation. Look for the morphology criteria. It's much, much easier, much quicker. Okay, what do you think, guys?
Come on, Justice. Oh, Srini. Srini is excited. Let's see.
Well, so going to the beginning of the strip, the native QRS complexes seem to be there. There's morphology of the native QRS. Then third complex is probably not the native. The fourth is probably not the native. And there's something that there's a spike, after which probably that's a Piest complex. I'm not sure what that is.
Yeah, interesting, huh?
Yeah, and the Piest, so it's a long interval, then the paced complex, and then there's another PVC, I might say so. That sets off probably a reentrant arrhythmia. Now it's quite wide. Lead 2, it's positive in lead 2, and so it's positive in lead 2. So I can't say if it's right or left bundle based on this. But regardless, even if it's a left bundle, it's quite wide QRS. The rate is close to 150. So this wide of a QRS with rate of 150, I would say it's DCT. Unless it will really surprises me. I would say this patient had a scar and there's reentrant arrhythmia.
So it's a VT?
Yes.
Awesome. So Baby Mansoor gave us this little mean tracing. So what is the underlying rhythm here? What do you think, guys? In this area. So Baby Mansoor, my goodness. So was
I think there is another one I sent. I don't know if you.
Yeah, there's another one you sent. And it comes at the end, yeah.
Yeah.
So
okay.
It's a little tricky tracing. But you have a very good. So what you see here, is this regular rhythm or not regular?
That's regular.
You sure?
I mean, at least we just have we have only 3.
We have 1, 2, 3, 4 beats, and then we have this here.
No, so the first, second, and fourth are similar. The third is probably a different one.
Right.
So
do you see me clear P waves here?
No, not clearly. Not clearly. So that's
not clearly, right?
Yeah, that's
ventricular. It makes me think. What is the supravector rhythm here?
Probably AFib.
AFib. Yeah, AFib. And that's typically what you see. And the patient has either defibrillator or a pacemaker, because what you see here, from here to here, enough time passes so that the time is up, and your pacemaker stimulates your ventricle.
Yeah, he has an ICD, primary prevention, that he has not used for 10 years.
Okay, so that's so I know he has AFib. So, and you get a very wide QRS complex here. So if you have a very wide QRS complex, that makes you think that this is most likely to be treated by the width criteria, right? But you also have to explain, you have a morphology, you have a PVC, followed by another wide QRS complex, so that might be another PVC. And then you have a run of wide complex tachycardia that looks completely different compared to the PVC here and PVC here. And that is typically what you see in scar-mediated ventricular tachycardia from the initiation. The morphology is often different than the initiating impulse that starts your VT. So this is 100% ventricular tachycardia, because now you have a very, very regular tachycardia, while the patient here was in atrial fibrillation. So you would have to explain, how does atrial fibrillation with aberrant conduction suddenly becomes regular? So everything screams here in this tracing, this is ventricular tachycardia without a doubt, right? So often if you have a tracing like this, you would look for AV dissociation, because you only have 2 leads available and the diagnosis is much more difficult. In this case, I think it's pretty clear your QRS complex is so wide that it's very likely VT, but you would see and look for AV dissociation. In this case, you have atrial fibrillation as underlying rhythm. Guess what? You won't see AV dissociation, which makes the interpretation a little bit more difficult. But I think we have enough information here that you can very confidently say this is ventricular tachycardia. Good.
Dr. Schmitt, I have a question. So there is also axis change, right? In tachycardia.
Absolutely.
Does it make any difference?
No, so yeah, it makes a difference, because typically if you see an axis change like this, unless you have a really typical morphology in respect to right bundle or left bundle matrock, this makes it a VT much more likely. Right. You're right. So this is a very different morphology here. And this is a criteria, PVC here, and induces a very different morphology compared to these PVCs here. So,
right.
Yep.
Thank you.
Oh, I brought it up early. Shoot, I meant to get it at the end. Okay, guys, what do you think about this? So this is another ECG that Baby Mansour.
Yeah, so I'm biased. I'm not gonna say anything, but I will challenge all the fellows. If you confirm my suspicions, Dr. Schmitt, I will be very happy.
All right.
But I may be wrong. Let's see.
All I can make out is the left rabbit ear is larger than the right rabbit ear. So right is bigger than the left. Sorry, yeah. That goes with VT, but we'll see.
Mm-hmm. Yeah. So the first question I have for you guys, is it wide or is it narrow?
It's wide.
It's wide.
It's wide? Okay.
It's 120 millimeters in V3.
It's whitish?
Whitish.
That you would see in a typical VT.
No, in V6 we see it's wide enough. It's
Yeah.
seconds at least.
You guys see that, right? Look. It's freaking wide here. And if you look here, that is freaking narrow. You agree? This is barely 120 milliseconds, while here it's much wider. Here, if you look here, it's barely 120 milliseconds, while in V6 it looks like 160. So therefore you get fooled. Okay. So what Bandelmann block is that?
Right bundle block.
Right.
It's right.
It's a right Bandelmann block, not 100% typical. So the RF here in V2 is pretty tall there, right?
Yeah.
Okay. And what kind of axis do you have?
Left.
Left axis deviation. Now you have right bundle and left axis deviation.
And our S ratio less than 1.
Okay. So, Baby Mansour, what do you think?
Yeah, so I was thinking VT based on this ECG because of all this wide, the atypical right bundle, the left axis, the RS ratio. And I'm trying to remember if there was an AB dissociation. I'm not very confident about it, but if you see...
It's difficult, right, to see,
But if you see, like I'm guessing, like on the... You see the morphology of the first few beats, it gets different. Like if you look at maybe the fourth beat, the after the T wave, they're not similar morphology. It gets changing. Whether that's a P wave or not, I cannot prove it, but it points towards it.
It's difficult, yeah.
I don't know what you make of the upstroke of the S on V4. Can we consider that as a criteria? I know they say the downstroke of the S, but there is a notch there in V4.
Yeah. You can't, probably not. You probably won't be able to use it. So this is VT, right? And what kind of classic VT is it? This is a idiopathic VT using part of your conduction system. So it's a Bellhazen ventricular tachycardia. So there are 3 different morphologies of idiopathic ventricular tachycardia using your conduction system, and that is the most common form that you see in 80 to 90% of the cases. So you have left axis deviation, and you have a right Bandelmann block morphology, and typically, in some leads at least, these tachycardias are relatively narrow, while other leads you see a little bit more wide. So if you use part of your conduction system, these tachycardias tend to be fairly narrow. So the left posterior fascicle is involved here. So you ablate this, you look for this area, and it's basically a micro-rearrangement circuit that you have. And because it uses part of your conduction system, typically the tachycardia is a little bit more narrow. So Bellhazen tachycardia.
Yeah, so that's the tricky part about this, Dr. Schmitt. I would just tell you briefly about the patient. She's a post-mitral surgery, and she had a circ that was iatrogenically sutured, so she has a big scar in the circ territory, the lateral territory.
Right.
So we were thinking, like, could this march with her scar location? like, so I'm questioning the mechanism. Is this just a
Right.
vesicular VT, or
Right.
something has to do with her scar?
That's a good point. I would think this is it's still idiopathic ventricular tachycardia, not scar-mediated. I would expect that this tachycardia would be much, much wider if you have a lateral infarct. I would expect in this area here a very wide QRS complex. I would expect an AVL a very wide QRS complex. So I think this is still idiopathic ventricular tachycardia, which you still can have, obviously, even if you have a scar in this lady. So is it someone here? Because one of my patients happened exactly the same thing.
No, different hospital.
St. Francis, different hospital, yeah. Okay. Good. So, one of my patients also got tethered during mitral surgery and got a big infarct.
Dr. Schmitt, I have a question. So you can see there are, I mean, I know it's VT, so the criteria for LVH, can we apply on this because AVL is like
no,
it's a voltage criteria, so
right, not during the tachycardia you can't, no.
Right.
Yeah. All right, guys. What time is it? Oh boy.
It's 8, but we can, if you have time, we're happy to go longer if that's
okay. Let me quickly, Okay. This is a tachycardia, I think, let's see what you think. I just have to have a cardioversion in a bit, but let's go at least 2 more tracings.
This is a wide QRS complex tachycardia.
Mm-hmm.
And, almost 150, greater than 150 per minute. And it's right bundle morphology.
Mm-hmm.
The QRS duration is close to 160 milliseconds.
Okay.
And I believe this is just it's entirely R and V1. The axis.
Okay, good. The question is not too typical. I mean, you could, but there's a little notch here, right? And then it goes down and up. Pretty much a monomorphic R wave in V1, right? Yeah, good.
So that favors VT.
Yep. So the width favors VT. The morphology in V1 favors VT. And morphology in V6 favors VT.
And the RS ratio favors VT.
Yeah.
And the axis is, I believe it's
the right axis. So it doesn't help you, right? If you have left axis deviation, it would, but the right axis doesn't help you, right?
Yeah.
Good. So you think it's VT?
It's VT. Yeah.
Good. Anybody thinks it's not VT? Silence. Raise your hands. No, I'm just kidding. So, listen, guys. You're absolutely right. This is 100% VT based on the morphology criteria in V1 and V6 alone. But I want to point you out something else. You have a R wave here. And what do you have in V2?
S wave, like a transition.
You have an S wave. Look, it goes from all positive to all negative, and you see something else. See that here? This little notch?
Mm-hmm.
You see this notching down?
Yep.
So this is the Josephson sign. That's another thing. And then, remember, positive R wave here, all negative S wave in V2, and then all positive R wave in V6. So in these 3 leads, you have go from R to S to R. Doesn't happen in bundle branch block in aberrant conduction, right? This is never a typical right bundle. So you have all signs that this is 100% VT. Good. So remember, take-home message from this EKG is, if you have aberrant conduction, you should have typical right bundle or typical left bundle. There's nothing typical in this ECG. This is 100% VT. Let me skip this one. We had one of this. Let me see one more. Okay. Let's do this the last one.
Who's going for it?
I can try. All right, so wide complex tachycardia. Axis is normal. It's kind of a left bundle-wide pattern. Trying to see if there are anything there in V1. Don't see any notching.
Oh, you're not allowed to look for
Yeah.
AV dissociation. It's forbidden. Unless you have really difficulties.
Looking for any AV dissociation, capture beats. I
Okay.
can't find any.
But you don't need this in this EKG.
Is it typical left bundle?
So just apply the morphology criteria.
So
You said this is left bundle branch morphology, right?
right, it is left bundle branch morphology.
Mm-hmm.
You can see, is it a typical left bundle? Not really.
Not really, yes.
Yeah, it is not.
It's not, no.
Oh, so
Good. So it's not a typical left bundle. So remember, one of the criteria is R wave V1 and V2.
right, which is not here.
R wave in V2. Big fat R wave.
Right.
It's
Yeah.
at least 30 milliseconds. So based on this alone,
This is like VT.
is VT. So, but also remember, a left bundle branch block, you do not have an R wave in V2, and certainly you not have a monomorphic R wave in V3.
Yeah.
It doesn't exist. You have if at all, you have a tiny R wave and deep S wave in V3, V4, and then transition to, so this is a very atypical left bundle.
Right.
So this cannot be aberrant conduction. This has to be ventricular tachycardia.
Right.
Okay, QS complex 160, so that doesn't help you, but the R wave here and the transition here to all R wave in V3, you do not have this in a left bundle. So remember,
Right.
if it's very atypical, it's VT. So this is an outflow tract tachycardia, could be the RVOT, but the transition is from V2 to V3. So this could be aortic cusp or the left ventricular outflow tract. So I have a high suspicion. So even in these tachycardias, they're usually not quite as wide, and yet they have these huge tall R waves in the inferior leads, 2, 3 AVF, that screams outflow tract tachycardia. So this is coming probably from the aortic cusp or from the left ventricular outflow tract. Okay, guys, but also for these tachycardias, the morphology criteria still apply. All right, I have to do a cardioversion, guys. We can go over a few next time, the ones we haven't seen, just to start our next session that we have next month, okay?
Awesome. So thank you very much.
All right, guys, have a good one.
Dr. Schmitt.